Welcome to the Hospital Medicine Unplugged podcast. Today, we're undertaking a really critical deep dive into what I think is a core competency for all of us as hospitalists, conducting evidence-based, structured goals of care discussions.
Yeah, absolutely. And look, this isn't just about documenting DNR orders, right?
Not at all.
It's really about mastering a type of communication that can fundamentally reshape patient outcomes, especially when they're at their most vulnerable.
Exactly. So our mission today really is to focus squarely on the evidence. We want to show how structuring these goals of care or GOC conversations and, importantly, moving them away from just abstract procedural discussions
Yeah, like a tech list.
towards truly patient-centered dialogues is, well, it's non-negotiable for high-quality medicine.
Completely agree. And the purpose, I think, is twofold. First, you want to clarify the patient's values, really understand their preferences, and make sure they genuinely comprehend their illness trajectory.
Right. The understanding piece is key.
It is. And second, you need to align the medical interventions we recommend and provide precisely with those foundational goals we just uncovered.
And when we talk about high-quality medicine, the value proposition here for doing these GOC discussions well is it's quantifiable. It's actually quite compelling when you look at the data.
It really is.
The literature consistently points to three key clinical outcomes. These impact both the patient experience and, frankly, resource stewardship in the hospital.
Okay.
So first, you see improved patient and family outcomes. This means things like reductions in emotion distress, lower rates of complicated grief later on, and just higher measures of patient satisfaction with their care.
That makes sense. Better communication leads to feeling more heard, less distressed.
Exactly. Secondly, and this is crucial for hospital operations, high-quality GOC discussions are associated with reduced non-beneficial interventions.
So less futile care.
Precisely. Fewer unwarranted or, frankly, futile ICU stays. Fewer intubations in patients who really aren't going to benefit. You minimize patient harm from aggressive treatments that might just prolong suffering.
And reduce healthcare waste at the same time.
Exactly. It hits both quality and efficiency.
Right.
And the third outcome, well, maybe it's the most fundamental. Enhanced goal concordant care.
That's the term we're always striving for.
It's the gold standard, isn't it? It means the care that's actually delivered, whether it ends up being aggressive intervention or comfort measures, is exactly what the patient, having fully understood their situation, truly wanted.
Yeah, this isn't just, checking a box for regulatory reasons. This is ethical medicine in practice.
Couldn't agree more.
Yeah.
But achieving that goal concordant care, it absolutely hinges on timing.
Oh, absolutely. The evidence is really strong here. Early initiation is key.
This is the paradigm shift we really need, isn't it? Moving away from having the conversation, in the middle of a respiratory crash or some other crisis.
Exactly. We have to proactively identify patients who need this discussion now, not wait until they're acutely deteriorating when, let's face it, anxiety, maybe delirium, cognitive impairment make meaningful discussion almost impossible.
So how do we make it proactive? We need to rely on established clinical triggers.
Right. And probably the most widely cited and maybe the easiest one to integrate is that prognostic indicator. The "would you be surprised if this patient died in the next year?" question.
The surprise question. Simple but powerful.
It is. If, as a seasoned clinician, your honest answer is, "No, I wouldn't be surprised," well, that patient should immediately be flagged for a GOC discussion. It doesn't matter if they look stable right this minute.
That's a really important point, regardless of current clinical stability.
Yes. Beyond that simple question, you look for combinations of factors that define high risk.
Okay, like what?
Well, acute clinical deterioration, obviously, that's a trigger. But also things like high-risk diagnoses, advanced, incurable metastatic cancer, for example.
Or severe end-stage organ failure.
Exactly, like end-stage heart failure with an EF less than 20%, or cirrhosis with a recent decompensation. Or think about advanced age coupled with, say, 3 or more significant comorbidities.
Things like frailty, dementia, chronic kidney disease.
Precisely those. We have to integrate these specific high-yield criteria systematically into our daily workflow, maybe even build them into our pre-rounding prep.
Yeah, make it part of the routine check. Okay, let's unpack this a bit more. We know when we should ideally have the conversation using those triggers, but I think every hospitalist listening knows why we often don't or why it's so difficult. We need to kind of map the minefield of common barriers.
Right. And it's interesting, when you look at large surveys of clinicians asking about the obstacles they perceive,
Yeah.
the highest rated barriers consistently are attributed to patient and family factors.
That's a critical distinction, isn't it? It suggests the primary hurdles are less about, say, the technical skill of the physician.
Although that plays a role.
Sure, but more about the immense emotional and cognitive load on the patient and their family unit during these times.
Exactly. The most common difficulty cited is the struggle to accept a poor or uncertain prognosis.
That cognitive dissonance.
It's huge. The patient might intellectually grasp the diagnosis. They hear the words metastatic cancer. But emotionally, denial, or maybe just intense hope for a miracle, it overrides the capacity for realistic planning right then.
And that difficulty is often made worse by the challenge of truly understanding the limitations and sometimes the severe complications of the life-sustaining treatments we offer.
Yeah. And for our audience, just saying limitations of CPR isn't enough, is it?
No way. We're talking about the reality, the frankly often low success rate for in-hospital cardiac arrest, especially in certain populations.
And perhaps more importantly, the high rates of subsequent functional decline, particularly in frail elderly patients. Survival doesn't always mean meaningful recovery.
Right. When a patient survives an arrest, their likelihood of returning to their baseline functional status, measured by things like the cerebral performance category, the CPC score, it's often severely compromised. Yet that reality is incredibly hard to absorb during a crisis.
Exactly. We need to communicate that CPR often means, sternal fractures, maybe a anoxic brain injury, prolonged ICU dependency, outcomes that many patients, if they really understood them, would define as an unacceptable quality of life.
Definitely. And then you frequently encounter the challenge of a patient lacking decisional capacity in the acute setting.
Very common. Which forces reliance on a surrogate decision maker.
And that brings its own complexity.
Oh, absolutely. It's often complicated further by a lack of agreement among various family members about what the goals of care should be. That creates this paralyzing ambiguity for the medical team.
You see that all the time. And we can't forget the raw emotional responses, either the anxiety, the fear, the outright denial. These are powerful psychological inhibitors.
They really are. If a patient is just overwhelmed by anxiety, their capacity to process the complex risks and benefits we're trying to discuss is severely curtailed.
That emotional distress actively blocks meaningful engagement and comprehension. It's like a shield goes up.
Precisely. Now, moving beyond the sort of interpersonal dynamics, we also face pretty substantial procedural and environmental barriers just within the hospital structure itself.
Okay, like what?
Well, a major one is the common practice of focusing the discussion almost exclusively on procedures.
You mean just talking about code status?
Yeah. Simply limiting the conversation to a binary choice DNR or full code is, frankly, a profound disservice to the patient and the process.
I agree. When we reduce the GOC discussion to only code status, the patient often perceives it as abrupt, maybe dehumanizing.
And maybe inapplicable to their current acute illness. They feel like they're being asked to just give up.
Right. And that approach skips the absolutely necessary step of grounding the decision in their core values, which inevitably leads to poor comprehension and unnecessary distress. It feels like a failure of communication design, systemically.
It really is. Moreover, the hospital environment itself often fights against having a meaningful conversation.
How so?
Well, lack of privacy is a big one.
Yeah.
Trying to have these incredibly sensitive talks in a semi-private room with just a curtain divider.
Yeah, that's tough.
And intense time constraints. Especially for hospitalists managing a high census, it's just challenging to dedicate the focused, uninterrupted block of time that a serious illness conversation truly demands.
It requires protected time, which is often scarce.
It does. And finally, let's touch on the system and physician-related barriers. The system-level issues are immense, particularly fragmented care.
Oh, yeah. Patients often have multiple specialists, different hospitalist teams rotating through.
Potentially leading to inconsistent messaging about prognosis or the plan, and then there are significant documentation challenges.
Finding previous GOC notes can be a nightmare.
Exactly. Crucial discussions from a prior admission or even a clinic visit are hard to locate, or they're recorded in non-standardized places within the EHR. It's not easily accessible.
And we have to emphasize, these system barriers are often dramatically more pronounced in racially or ethnically minoritized populations.
That's a critical point. Studies consistently show they are statistically less likely to have documented goals of care discussions.
And that disparity is often rooted in structural issues, right? Things like implicit bias in who gets identified proactively for these talks.
Inadequate language access services, historical distrust of the healthcare system because of disparate treatment. This inequity demands a focused systemic fix. It's not just about improving individual bedside manner.
Absolutely. It's a system problem requiring a system solution.
Yeah.
Now, while physician-related barriers, things like lack of confidence, maybe insufficient communication skills training, or just discomfort with emotionally charged topics, they're certainly present.
And we need to address training, for sure.
We do, and we will later, but they are generally rated lower in clinician surveys than the patient-family factors or the structural ones.
Which suggests that while training is essential, really addressing the systemic fragmentation and the emotional context is probably paramount for truly moving the needle on GOC quality. And that analysis leads us directly to the kinds of structural solutions that are required. Because the barriers are so deeply systemic and structural, the interventions have to be systematic, multifaceted, and honestly technology-enabled in today's world. We now have pretty strong evidence supporting system-level interventions designed to improve both the frequency and the equity of these crucial discussions.
So EHR integration sounds like it's the cornerstone here.
It really is. We need automated electronic health record-based clinician prompts. And these aren't just generic reminders like, hey, think about GOC.
Right, they need to be smarter.
Exactly. Sophisticated triggers often linked to the criteria we just discussed, the surprise question, or specific prognostic scores like frailty indices, maybe recent multiple ICU admissions, things that flag high-risk patients automatically.
Okay. And beyond just prompts.
Well, we should be utilizing patient-specific communication priming tools. A great example, often integrated into the EHR, is something called the Jumpstart Guide.
Jumpstart Guide, what does that do?
So this tool doesn't just remind the hospitalist to talk to the patient. It actually summarizes all the relevant, often disparate EHR data needed for the discussion in one place.
Ah, okay. So instead of me manually digging through years of notes from different specialists.
Right. The system aggregates, say, the trending functional status, the date of the last oncology consult, recent ID history, any prior documented code status discussions. It pulls it together.
That saves a huge amount of time and effort.
It does. And it might even offer templated language tailored to the patient's diagnosis. It functions almost like a mental checklist or a briefing sheet for the clinician before they go in.
And what's the impact of tools like that? Especially thinking about equity.
Well, the impact is pretty profound. Clinical trial data confirms that automated prompts in these kinds of guides significantly increase the documented rate of GOC discussions.
Okay.
And critically, this improvement has been shown to be significant among patients from minoritized racial and ethnic groups. So it demonstrates a measurable reduction in that equity gap for GOC documentation, simply through standardization and system support.
That's powerful. Just making it systematic helps close the gap.
It seems to. Now, beyond just triggering the conversation, the documentation itself has to be highly structured.
What do you mean by structured?
We need dedicated, maybe even mandated, EHR sections specifically for recording and retrieving patient values, goals, and preferences, not just a single checkbox for code status.
Got it. A dedicated space for the narrative.
Exactly. This structured format ensures that the information is easily accessible to the entire care team. It makes it truly actionable when a critical decision needs to be made by the covering person at 2 a.m.
Right. If a patient clearly states their primary goal is to return home and be able to garden, and their absolute unacceptable outcome is permanent reliance on a ventilator.
That must be recorded explicitly accessibly. It prevents that fragmentation we talked about. It supports care continuity across shifts, across different services, maybe even across institutions if the notes are shared. It reinforces their preferences every time someone new reviews the chart.
Makes sense. And we can't discuss standardization without focusing on the clinician skills, right?
Absolutely not. We need robust communication skills, training, and coaching. And this has to go beyond just, didactic lectures in a conference room.
Yeah, sitting through a PowerPoint doesn't really cut it.
Not for this. We need simulation-based training. Ideally, opportunities to get feedback on real-time conversations, maybe through trained observers or using standardized patient encounters.
That hands-on practice and feedback loop.
That's what builds true confidence, and it significantly improves the quality of the interaction, which is the very metric that seems to drive patient satisfaction and better outcomes.
Okay. Training, system prompts, structured documentation. What else?
Well, Accountability is essential for sustainability.
Yeah.
We need systematic patient identification using those triggers we discussed, ensuring timely GOC initiation across the service as a standard practice.
And measuring performance.
Yes. We need performance measurement of documentation quality. If we start tracking, say, the percentage of patients with advanced illness who actually have a values-based GOC note documented, and then provide consistent, transparent feedback to the hospitalist teams, that supports sustained improvement. It maintains accountability for this really high-value activity.
All right, so now that we've kind of laid the groundwork for the systemic structure needed, let's break down the actual evidence-based choreography of the discussion itself. Let's start with step 1. Preparation and opening the conversation.
Okay.
As physicians managing high acuity patients, preparation is just crucial, isn't it? Anticipating potential landmines can often prevent them from detonating in the middle of a sensitive talk.
Couldn't agree more. Preparation starts with a really rigorous patient review, not just a quick chart flip before you walk in.
Right. What should we be looking for?
You have to proactively review the medical record for any prior advance directives, any previously documented code status, or any GOC discussions from other services, oncology, cardiology, primary care notes.
And the key framework here, I think, is to honor those prior efforts.
Yes. Ask, has anything changed since the last time you discussed this? This validates the patient's past experience and avoids making them feel like they have to repeat their entire story over and over.
Good point. What about mental readiness for the clinician?
Equally important, we need to consciously anticipate and maybe even categorize potential emotional responses we might encounter, anxiety, grief, anger, and also identify likely barriers specific to this patient. Is there low health literacy? Are there language barriers? Are there complex, potentially conflicting family dynamics we need to navigate?
So preparing mentally allows you, the clinician, to remain centered and empathetic when the conversation inevitably hits an emotional rough patch.
Exactly. It helps you not get thrown off course. And then you absolutely must set the stage. This is non-negotiable for these high-stakes discussions.
Meaning find a private space.
Find a private, interruption-free environment. That might mean requesting a conference room, making sure pagers are silenced or handed off, and explicitly allocating enough time.
Yeah. An effective GOC discussion just cannot happen effectively while you're leaning over the bed rail during busy morning rounds in a noisy multi-bed ward.
It just can't. So once you're prepared, the opening strategy is really everything for building rapport and starting to elicit understanding.
Building trust right from the start.
It's foundational. We have to foster a relational connection, demonstrate genuine empathy. You can start by explicitly acknowledging the emotional difficulty and stress that's just inherent in these conversations for the patient and their loved ones.
How might that sound?
Something as simple as, look, I know this is likely a difficult conversation to have, and I really appreciate you taking the time to talk with me today. Just opens the door gently.
That emotional acknowledgement sort of normalizes their distress, doesn't it?
It does. And the next critical maneuver is to elicit their baseline understanding before you start presenting any new medical information.
Assess first.
Always assess first. We have to understand the patient's existing comprehension of their medical situation and their prognosis. If you jump straight to treatment options without first understanding what the patient believes is happening to them,
You're setting yourself up for misalignment.
it's the quickest path to misalignment and potentially non-beneficial interventions because you haven't started from their reality.
So how do we assess that understanding effectively?
Through open-ended questions. Questions designed to facilitate patient agency and narrative. You have to avoid clinical jargon and definitely avoid closed questions that just solicit a yes or no.
Give me an example.
Instead, use phrases that invite them to tell their story, like, can you tell me in your own words what you understand about your current illness? Or maybe, what are your preferences for how involved you'd like to be in making these tough medical decisions?
That signals that their voice, not just their chart or lab values, really matters in this process.
Precisely. It sets a collaborative tone from the outset. Okay, so moving into step 2, this section is all about exploring the patient's values, their goals, and also their fears. And this requires a very deliberate shift to patient-centered language.
Right. This is where we have to consciously avoid that procedure-focused language we talked about.
Yes, eliminate the medical jargon.
Personalization and trust building become even more critical here, especially since these complex conversations often happen during an acute illness when the patient is feeling particularly vulnerable.
Exactly. The goal here is to really drill down on their core values and priorities. We need to understand what gives their life meaning, what makes life worth living for them.
How do you get at that?
You use values-focused questions. Things like, looking ahead, what is most important to you if your health situation were to worsen significantly? Or maybe, what specific things are you hoping for from your medical care as we move forward?
So you're aiming to understand the patient's definition of a meaningful existence, not just whether we can achieve some functional clinical milestone.
Precisely. And this exploration often requires discussing some difficult trade-offs, specifically the trade-off between function and longevity.
Can you give an example of that?
Sure. Some patients might prioritize maximizing time, even if it means accepting potential ventilator dependence or a severe decline in their functional status.
Others might view a certain level of, say, cognitive decline or the inability to care for themselves as an unacceptable quality of life, regardless of how long they live.
Exactly. And we need to clearly identify those unacceptable outcomes for that specific patient.
That distinction, what is unacceptable to them, is absolutely vital for clear alignment later on when making recommendations.
It is. We have to ask pointed questions, perhaps gently, but pointedly. Like, what are the limits of intervention for you? Or, if you reached a point where you couldn't recognize your family or couldn't communicate your needs, how would you view that quality of life?
Clarifying those deep-seated concerns allows us, together with the patient, to sort of draw a line in the sand. It ensures we don't inadvertently cross their personal threshold of what they consider unacceptable suffering.
Well said. And we also must proactively try to uncover their fears.
How do you approach that?
Just ask directly, but supportively. Something like, what are you most worried about right now regarding your illness or what the future might hold?
And that gives you a crucial opportunity to address specific anxieties they might have.
Exactly. For a cancer patient, the fear might be uncontrolled pain. For someone with advanced heart failure, maybe it's repeated hospital admissions and losing their independence.
And addressing those fears directly allows you, the clinician, to tailor the care plan to specifically mitigate those anxieties, which is in itself a powerful demonstration of patient-centered care.
It really builds trust. Now, within this step of exploring values and fears, we also have to try and stabilize the family dynamic if family is present.
Okay. What does that involve?
We need to clearly clarify the role of the family in the decision-making. Are they there primarily for support, for information gathering, or do they hold actual decision-making capacity as a surrogate?
And identify or confirm who the legal surrogate decision maker is?
Absolutely critical. Because family disagreement is such a profound barrier to achieving goal-concordant care, proactively establishing that decision hierarchy can prevent significant conflicts down the road, especially when critical decisions need to be made quickly.
Okay, we move now to step 3. Sharing medical information and assessing understanding. This feels like the synthesis step where we connect the patient's values we just explored to the sometimes harsh reality of their medical condition.
That's a good way to put it. As hospitalists, we're generally adept at presenting the diagnosis and the current status, but the focus here really has to shift towards a realistic, evidence-based prognosis.
And sharing prognosis requires both clinical honesty and compassionate delivery, right?
Absolutely. It's a delicate balance. We have to discuss the expected disease trajectory. That includes estimated risks of mortality, yes, but also the likelihood of functional impairment and the potential for cognitive decline based on their specific condition.
So, for example, discussing the likely outcomes of severe pneumonia in a patient who already has advanced dementia.
Must include the high probability of them not returning to their prior baseline function, even if they survive the pneumonia.
Right. And we also must clearly discuss the benefits and the burdens of all the reasonable therapeutic options.
This is where we contextualize those life-sustaining treatments, CPR, mechanical ventilation, dialysis, directly in light of the values the patient just shared with us.
Transparency about the burdens is required for true informed consent.
Completely. We have to articulate not just the statistical chance of survival, but the potential implication of that survival for their quality of life, their long-term functional status, based on what they told us matters most.
Okay, so we're sharing this complex, often difficult information. How do we ensure comprehension? The delivery must be paramount here.
It really is. We should provide information in small, manageable segments, sometimes called chunking. Break it down.
Avoid overwhelming them.
Exactly. And crucially, it's often best practice to ask permission before sharing new or particularly difficult information.
How does that sound in practice?
Something like, I have some new information about how your heart is functioning. Would you be ready to hear about that now? It respects their emotional capacity and gives them a measure of control over the pace of receiving potentially bad news.
That makes a lot of sense. And central to this step is constantly checking for understanding, right? Integrating that ask-tell-ask approach.
Yes, the clinician tells the information,
Yeah.
but then periodically asks the patient or family to summarize what they've heard in their own words. Ask.
Can you give an example of the second ask?
Sure. Okay, I've told you quite a lot just now about the risks and potential downsides of being on a ventilator. Just to make sure we're on the same page, can you tell me back what you heard about what that might mean for your day-to-day life if things went that way?
It closes the loop. It's really the only reliable way to identify profound misunderstandings, which we know are incredibly frequent in these high-stress medical environments.
Absolutely. Furthermore, tailoring the discussion is essential for both equity and efficacy. We have to adapt our language, our tone, our focus based on the patient's primary language, their cultural context, their health literacy level.
Which means consciously eliminating medical jargon.
Definitely. And if necessary, utilizing certified medical interpreters and perhaps culturally informed medical staff if available.
What about things like decision aids? Brochures, videos?
They can be helpful adjuncts sometimes, maybe to reinforce learning after the conversation, but they must never be used as a substitute for that direct, meaningful dialogue between the clinician and the patient or family. The relationship is key.
All right, moving into step 4, this is where we transition from understanding goals to actually discussing and implementing concrete treatment decisions. And the key principle here is that our recommendations must be explicitly aligned with the patient's stated values we uncovered earlier.
Exactly. So, if the patient prioritizes life extension above all else, and they fully understand and accept the potential risks and burdens of aggressive care that we've discussed.
Then life-prolonging interventions are appropriate and goal-concordant for that individual.
Correct. However, a very common clinical scenario we face is prognostic uncertainty. What do we do when the outcome is genuinely unclear?
That's where time-limited trials come in.
Precisely. When the outcome is genuinely uncertain, we should advocate for time-limited trials of aggressive care. This strategy is highly supported by guidelines from major societies like the American Heart Association and the Society of Critical Care Medicine.
And the key is that a time-limited trial is not an open-ended commitment.
Absolutely not. It must have predefined goals. What clinical improvement are we hoping to achieve? And clear endpoints for mandatory reassessment, usually within a relatively short time frame, like 48 to 72 hours.
This structured approach prevents treatment from just sort of drifting along into futility without a clear decision point.
Exactly. For instance, you might initiate a time-limited trial of non-invasive ventilation with the explicit goal of seeing improvement and potentially being off the device within 48 hours.
And if the patient hasn't improved by that endpoint,
Then the conversation shifts naturally. It's not, do we just continue indefinitely? It becomes, we agreed we would reassess now, and unfortunately the goals we set haven't been met. So based on that, what should our next steps be, aligning with your overall priorities?
it provides a structured off-ramp if needed.
Yes. Conversely, for patients who prioritize comfort, quality of life, and symptom management above longevity.
Then comfort-focused care is the recommended goal-concordant path.
Right. This involves consciously deciding to withhold or withdraw life-sustaining treatments that are not aligned with their goals, and instead prioritizing comprehensive symptom control, managing pain, shortness of breath, anxiety, spiritual or psychological distress effectively.
And this is often the appropriate time for referral to specialized hospice and palliative care services.
Very often, particularly for managing complex symptoms or for patients who wish to receive comfort-focused care outside of the acute hospital setting, perhaps at home or in an inpatient hospice unit.
Okay, let's turn for a moment to the structured communication tools that can help standardize this complex process. 2 guides frequently come up in the literature: the Serious Illness Conversation Guide, or SICG, and the SPICE protocol. For our purposes, discussing goals of care in the hospital setting, the evidence seems to strongly favor the SICG.
It really does. The SICG demonstrates superior evidence, and that's based on randomized controlled trials, which is high-level evidence.
And what benefits are associated with using it?
Its structured approach is associated with measurable patient-reported benefits. Things like increased patient understanding of their prognosis, statistically significant reductions in anxiety and depression related to their illness, and also a quantifiable improvement in the therapeutic alliance, the connection between the patient and the clinician.
Those are really robust, positive psychological outcomes.
They are, and it's fascinating to look at why the SICG might be superior in this context.
Go on.
It's structured to explicitly offer empathy and emotional support before delivering difficult prognostic news. Then it immediately pivots to eliciting the patient's values, ensuring their voice shapes the subsequent care plan.
So the structure itself promotes patient-centeredness.
Yes. And its language is intentionally designed to pivot away from just procedures and towards patient capacity and function, focusing on questions like, how much suffering is too much for you, rather than simply, do you want CPR?
How does that compare to spikes?
Well, SPIKES is certainly a useful component framework. It's actually recommended by ASCO, the American Society of Clinical Oncology, primarily for the task of delivering bad news effectively and ensuring comprehension.
Right.
But it lacks the same level of high-quality trial data demonstrating a comparable impact on overall patient psychological outcomes or achieving goal-concordant care in the way the SICG does. The SICG integrates the bad news delivery into a more comprehensive planning framework that includes values elicitation and recommendations.
Got it. So regardless of the specific tool used, critical decisions like code status still need to be addressed.
Absolutely. But the key is we must avoid isolating the code status discussion. It has to be addressed as just one part of the broader GOC discussion, grounded in the patient's stated values and goals we've uncovered. It should never be presented as some standalone procedural checkbox handed out by a resident on rounds.
That context is crucial. What about the specific language, like do not resuscitate versus allow natural death? Does the evidence say one is better?
Interestingly, recent studies suggest the choice of that specific diction doesn't seem to significantly affect patient satisfaction. The critical factor appears to be clarity, ensuring the patient truly understands the clinical consequences of the order, whatever words you use.
Clarity over specific phrasing.
Seems so. And finally, we must always adhere to the principle of iterative reassessment. These decisions are not static, set in stone.
Right. Circumstances change.
Exactly. They must be revisited and potentially updated as the patient's clinical status evolves, or certainly after a time-limited trial has reached its predetermined endpoint and a new decision point is needed.
We arrive now at what might be the most challenging, yet maybe the most essential. Skill for truly effective GOC discussions. Responding effectively to emotion.
Yes. This is tough, but so important.
The rationale for needing a structured way to approach empathy, it seems rooted in cognitive science, right? Emotional distress, when it's just left unaddressed, acts as a significant barrier. It impedes comprehension, it inhibits effective decision-making.
Absolutely. The Society of Critical Care Medicine actually recommends integrating structured empathy into these conversations precisely because research confirms it measurably improves both the quality of the communication and the likelihood of reaching goal-concordant decisions.
So we often talk about the NRS framework as a tool for this. Why NRZ?
Well, mostly because it provides a reliable, relatively easy-to-recall cognitive roadmap for clinicians when they're confronted with a patient's raw emotions, sadness, anger, fear. It gives you something concrete to do in those difficult moments.
Okay, let's break down the mechanics of NRS then. Starting with the N, that's for name the emotion.
Right. This means explicitly identifying and just articulating the feeling that you observe the patient displaying.
So if a patient's eyes well up with tears when you're discussing prognosis,
you might gently say something like, I can see that this news is upsetting you, or it sounds like you're feeling quite worried. Just naming the emotion validates their experience almost immediately.
Okay, that's N. Then U is for understand.
Yes. This step is about demonstrating your understanding by reflecting the emotion and its context back to the patient. It shows you've listened not just to their words, but to the feeling behind them.
How might that sound?
For example, it makes perfect sense that you feel worried and overwhelmed right now, given everything you've been through during this hospitalization. This helps shift the interaction from being purely clinical to feeling more like a trusting partnership.
Got it. Next is R for respect.
This involves acknowledging the patient's strength, or their perspective, or simply the effort they're putting into dealing with an extremely difficult situation.
Right.
You could say, I really respect how much effort and thought you are putting into making this very difficult decision, especially while you're also feeling unwell and fighting this illness. It reinforces their role as the active, respected decision maker in the process.
Okay. Then S is for support.
Here, you offer direct reassurance and partnership. You want to reduce the patient's sense of isolation in this difficult moment.
So a supportive statement might be,
Something like, I want you to know that we are here for you and our team will help you through this difficult process. You are not alone in this. Simple, direct, supportive statements can really lower anxiety and help prepare the patient emotionally for the next cognitive step.
makes sense. And finally, E is for explore.
Right. This invites further discussion to uncover the underlying values or the specific sources of the distress you just named and understood. It helps transition the conversation back towards planning.
How do you phrase that exploration?
You might ask, can you tell me a little more about what worries you most about that possibility right now? This allows the clinician to channel that emotional energy that surfaced into actionable planning. You can directly link the fear they express, like fear of pain, to a concrete goal, like ensuring robust pain control as part of the plan.
So implementing the NRS framework helps move the clinician beyond just spontaneous, maybe awkward emotional reactions.
Towards a structured, more therapeutic response. It's a really powerful technique to manage those emotional barriers, ensure the patient feels profoundly heard, and ultimately facilitate better comprehension of the complex medical information that's necessary for making these really tough decisions.
Okay, so to synthesize this deep dive into evidence-based practice for goals of care discussions in hospital medicine, we've really identified several core pillars, haven't we?
I think so. Effective GOC discussions must be initiated early based on those triggers. They have to be executed systematically using structured approaches, and they must be fundamentally centered on the patient's unique values.
And they should utilize structured, evidence-backed tools, like the Serious Illness Conversation Guide seems particularly strong. And this entire process needs to be supported by those crucial system interventions we discussed. Robust EHR prompts that also help drive equity, structured documentation templates, and specialized ongoing communication skills training for all of us.
Right. We also detailed the importance of that thorough preparation before you even walk in the room. The structured steps required for opening the conversation effectively, building rapport, and the absolute necessity of truly eliciting values before you start discussing specific treatments.
And then we covered the critical need to align our recommendations, whether they end up being life-prolonging care, clearly defined time-limited trials, or a shift to comfort-focused care precisely with the patient's stated goals and priorities.
Absolutely. That alignment is key.
So here's the final thought, and maybe the critical call to action for every hospitalist listening today. We need to revisit the foundational importance of documentation.
Ah, yes, the documentation piece, often overlooked, but so vital.
We know that clear, values-based documentation recorded properly in a dedicated, standardized section of the EHR is far more than just some regulatory requirement or a billing necessity.
It's much more than that. It is the essential structural mechanism that ensures the patient's values and preferences. The core of these conversations are actually accessible and truly actionable for every single member of the care team.
Right, from the consultant who sees the patient briefly, to the bedside nurse providing hour-to-hour care, to the next hospitalist who picks up the chart on night float or the following day.
Exactly. This high-quality, accessible documentation is what actually ensures care continuity during those critical transitions, whether it's a transfer to the ICU, a move to a long-term care facility, or even just during a simple 12-hour shift change.
So our challenge to you, the listener, is really a structural one. Take a hard look at your current workflow, at your institution's EHR setup. What steps can you take starting today to improve the accessibility and the standardization of prior GOC documentation on your service?
Because achieving that structural accountability around documentation, making sure these vital conversations are not lost in the chart, that's truly how we drive the highest quality of genuinely goal-concordant care for all our patients.